Sobabili siyathandana singamathenolimi iyo awethina sobabili siyathandana singamathenolimi iyo awethina sobabili siyathandana singamathenolimi iyo awethina sobabili siyathandana njengamathenolini we from isuka lenjani ngicela ukukubona ngavele ngasangana ngathi uye lona umaqondana wami angisifela nawe nomuntu wakho nemalini sinamashada siyeferisi njengophi.
Colleagues, let me welcome you to this session. Just one more minute and we'll start. We're missing one presenter, but to be respectful of time, I think we will just start. If the presenter comes, then we'll see how we can accommodate that. I believe today we'll be listening to a minimum of two excellent work done on the African continent that will showcase HIV and non-communicable diseases, comorbidity. We know there is a bidirectional relationship between risks between HIV and NCDs. People living with HIV/AIDS are more likely to develop non-communicable diseases, and also the relationship goes in the other direction. And we have now seen a lot of people living with HIV/AIDS getting to the age that traditionally is the age where the risk for non-communicable diseases becomes more increased, and it means it's going to become a more and more issue, and we need to see how we can integrate the HIV programs and the non-communicable disease programs so that we treat, frankly, everybody in this space as a human being, not in a highly vertical way. And we reduce the missed opportunities to get treatment for those who have comorbidity of both HIV/AIDS and non-communicable diseases. One of the enduring memory I'm going to leave ICASA with is listening to in a side event where a person living with HIV/AIDS talked about how being able to get screened for cervical cancer made her to live to this stage. We all know the prognosis for cancer of the cervix, but she was able to. She had HIV. She was able to get early screening and realized that she has some cancer cells, early stage. She got treated, cured. Cancer of the cervix is a curable cancer if detected early. And she lived to see her grandchildren. This, in my mind, summarizes why we need to integrate HIV treatment and the non-communicable diseases. So, without wasting much time, please, if the third presenter comes in, just feel free to join us here on the high table and we will take your presentation. But we're going to start this session with Dr. Alvarin Mutangere, who is going to talk to us about the diabetic screening among people living with HIV in Zimbabwe. Obviously, that is something that is of interest because we know that as people begin to develop diabetes, if you do not screen and take care of it in very early in the, on, then you open space for complication. Dr. Alveri, you're welcome, and please, if we can put up slides, and then he talks about it. Over to you.
Hello. Okay. So thank you so much for this opportunity for us to share our experiences in screening for diabetes among people living with HIV. My name is Dr. Alvin Mtengerere, and I work with Solidamet in Mashingo province. It's a Swiss organization which supports healthcare in Africa. So, next slide. So this is going to be the outline of my presentation. I'm going to just dwell a bit on the background, but more on the findings and lessons learned for our initiative. Next slide. So this is just talking about the growing burden of NCDs and also the prevalence of HIV in Zimbabwe. We have more than 1.2 million people who are living on ART, and of these, of notice that we need to know that there are so many people living with HIV who are also now aging. As you can see, more than 23% are on ART above 50 years. And then as for the NCDs, we all know that NCDs, they are on the rise. And in our country, they are accountable for more than 33% of the deaths. And one of the things on the response for NCDs is screening, early detection, diagnosis, and treatment of these NCDs before development of complications. And then the interventions for NCDs in HIV, in most of the facilities, they are not integrated, they are operating in silos. And so this is going to be shown in our discussion. Next slide. This slide is just showing what I've talked before, that quite a number of people living with HIV are now also aging. As you can see, more than 53% of people living with HIV are above 40 years. And when we get to the ages of 40 years, then we are also more prone to developing NCDs, with diabetes being among them. Next slide. So just a brief background of our organization. We work primarily with the Ministry of Health, doing health system strengthening. We are a Swiss organization, we work in various countries in Africa and also in India. And in Zimbabwe, we work primarily in Mashingo, and those are some of the clinics where we operate from. Next slide. So in terms of NCDs, we've been supporting NCDs since 2015, where we started with doing some situational analysis. Implementation started in 2018, supporting facilities in the 4 districts of Mashingo, which are Mashingo, Bikita-Zaka, and Chiredzi. And the NCDs that we initially started supporting were hypertension and diabetes. Though at present, we are also now supporting some severe NCDs under the PEN Plus initiative. But of note is that in 2022, that's when we introduced DM screening among people living with HIV. Next slide. So how did we do it? We started by training Ministry of Healthcare nurses to be able to screen, diagnose, and manage diabetes. And these healthcare workers are the healthcare workers who are working at the HIV clinics. We also noticed the gap in equipment and consumables, which we also managed to fill in terms of BP machines, glucometers, and also the strips at these facilities. We developed some registers so that we can be able to capture the information on the screening of DM among people living with HIV. And then that's when we introduced the annual screening of DM among all people living with HIV. And so when someone got screened and they had an elevated blood sugar level, they were referred to the NCD clinic for confirmation of diagnosis and initiation of treatment. Next slide. So for the 18 facilities where we were working, there were 13,072 people living with HIV registered in those facilities. But during the 9-month period of when we started this screening, only about 6,500 patients were living with HIV attended these facilities for care. And we managed to screen 3,720 people, and of these, 79 had elevated blood glucose levels. Next slide. So this is just showing the age distribution of the people whom we screened. And as you can see, from 30, we start to see an increase in the number of patients that were screened. So this just shows that most of the people who are living with HIV are now aging. Next slide. So 79 of the 3,720 had elevated blood glucose levels, and then diagnosis was confirmed using fasting or HbA1, fasting blood sugar or HbA1c, and 49 patients were were diagnosed with diabetes and initiated on treatment. Next slide. So this is just showing the prevalence of diabetes per age group. So as you can see, we start to have more diabetic patients with aging, which is actually also going on with what we've been discussing. Next slide. So these are some of the lessons that we learned through this implementation. This is not a research, but it is just implementation. So screening at health facilities only is not enough. We realized that there were so many people living with HIV who did not come to these facilities, and we assumed that this could be due to the community art refill groups, which are also good. So it's something that we noticed that if you want to get a good coverage of all the patients, screening only at the facilities is not enough. We need to move into the community. And then one other thing is that there were parallel systems in terms of the management of diabetes and also the diagnosis of diabetes at these facilities. So these patients were screened at the HIV clinics, but the healthcare workers at the HIV clinics were not confident enough to be able to diagnose and initiate treatment for diabetes. So if someone screens as a high RBS, they will then send that patient to the NCD clinic where confirmation of diagnosis and initiation of treatment was done. But you also see that this is a loophole. Some of the patients maybe that you can send for confirmation of diagnosis may not even get there. And also in terms of treatment, it's also cumbersome for these patients to be able to say, I'm receiving my treatment for HIV at the HIV clinic, and then for the diabetes or hypertension at the NCD clinic. And then one of the lessons learned is that we trained the healthcare workers at the HIV clinics to be able to screen, diagnose, and manage diabetes mellitus. But however, still with that initial training, they were not confident enough to be able to diagnose and also initiate treatment for diabetes at the HIV clinics. So we realized that this is something which needs more continuous training, including some on-site clinical mentoring, so that they can be able to boost their confidence to be able to diagnose and treat diabetes as well. Next slide. So our next steps involves more training on the HIV nurses to boost their confidence to diagnose and manage and also monitor diabetes at these facilities. And there is need for integration of NCD services into HIV, such that there is a one-stop shop for the people living with HIV. If they are coming for their HIV visit, then at the same time, they are also supposed to receive their NCD treatment under one roof at the HIV clinic, not actually sending them to the NCD clinic and then get their treatment for the NCDs. And we need to also advocate for more funding towards the screening of NCDs among people living with HIV, and also in general integrating NCDs with HIV. HIV is well funded, the HIV program, but however, as we can see, these patients are now aging and they are now also catching up with the NCDs. So they are funded for the HIV, but for the NCD component, it's not funded. They get medicines for the HIV, for the NCD, they don't get it. So I think we need to advocate for more funding so that we can also tackle the NCDs that they may develop. Next slide. So in general, we just realized that by addressing the dual burden of HIV and NCDs, we can overall improve the disease outcomes and also quality of care and quality of life for the people living with HIV. Thank you.
Thank you, Dr. Thank you, Dr. Alvarin. Excellent presentation. We know the 1.8 million people living with HIV/AIDS in Zimbabwe, they are aging, and they will require the risk of developing non-communicable diseases is rising. And indeed, your screening have shown that a significant amount of them have diabetes mellitus. But again, quickly, the health challenges came in. Out of 79, maybe you were able to treat 40 something, meaning some are not under treatment. And you've explained some of this, even though you try to intervene by training the health workers working with them. But again, that is not just enough. We need to do a whole health system approach to see, and to be good to you use nurses, and some people are even talking about using community health workers to deliver this, and nurses are having challenges. So we'll see how maybe as you go forward in this, how we can some of these health. We have several models. Maybe at the end we'll discuss that a bit further. But before we go, because we have two presentation instead of three, let me ask you, what were the main, apart from the fact that some of the health workers find it difficult to initiate treatment, but you were able to treat about 40 something of them. What was the main challenge behind not being able to treat the remaining maybe about 20 from your that did not get any treatment at all? Can you just expatiate? And
so thank you so much. So as you noticed, we said 79 had high random blood sugars, and then they were sent for the confirmation of treatment. So the 49 are the ones who were confirmed to have diagnosis. The others did not have diagnosis. Some of them were diagnosed with pre-diabetes, but once diagnosed with pre-diabetes, we also offer you health education and diet and lifestyle changes so that we prevent that patient from maybe developing overt diabetes or actually delaying the development of overt diabetes. So these were the only ones who actually confirmed the diagnosis with fasting or fasting blood sugar or a HbA1c. Thank you.
Thank you, Dr. Alvarin. We will open to the floor, but let's take the second presentation. Then we will open up for question. So for the second abstract, we have Dr. Charlotte Tanderera, who is also from Zimbabwe, and she's going to be talking to us about integrated HIV geriatric clinic that they've been doing, and it will really be an excellent experience to see what results they've achieved and the challenges thus far. Over to you, Dr. Charlotte. Can we bring back the slides?
Thank you. I'm going to be talking to you about the integrated HIV geriatric clinic model that we have been using at Newlands Clinic, which is based here in Harare. Next slide. So as a background, we do know that people are aging with HIV, and this is thanks to effective antiretroviral therapy. So projections are that by 2040, about 10 million people will be living with HIV who are aged 50 or older. So why is this information important? It means that we are going to need to change the way that we are managing people living with HIV. There's going to be more focus on challenges that are faced by people who are getting older. Some of these challenges include higher prevalence of non-communicable diseases, high prevalence of geriatric syndromes, and high prevalence of multimorbidity. Next slide. So in high resource settings, there's been a lot of models of care where they've integrated HIV and geriatric medicine, but we don't have a lot of data in low resource settings such as our own, where we don't have a lot of clinicians who have got geriatric experience. So today I'm going to be talking to you about how we have tried to integrate HIV and geriatric services in a low resource setting. Next slide. So the Newlands Clinic model. So Newlands Clinic is a public-private partnership. This is a Swiss-run NGO, which is in partnership with the Ministry of Health of Zimbabwe. And we have a clinic which takes care of over 8,000 people living with HIV. So in this integrated HIV geriatric care model, we use comprehensive geriatric assessments. So the model was based on the World Health Organization's integrated care for older people, the ICOP guidelines. So some of the, so what exactly do we look at when we're trying to do a comprehensive geriatric assessment? So we looked at markers of physical health, including frailty. We looked at mobility, falls, incontinence, mental health. We looked at hearing and visual assessment, nutrition, polypharmacy, and of course, we also looked at the HIV care. So this is a package which was looking not only at how HIV was well controlled, but also the other components of a comprehensive geriatric assessment in somebody who's living with HIV. So we used various tools to screen for these domains. I won't go into detail about the specific tools that we used because of the sake of time, but the tools that we used were based on regional validation and also feasibility of using them in our setting. Next slide. Okay, so Newlands Clinic has got over 448 patients who are aged over 65 who are living with HIV. And as part of this integrated HIV geriatric clinic, what we did was at least once a year, we our clients come and have this comprehensive geriatric assessment. So this comprehensive geriatric assessment comprises of two parts. So there is one where the clients are seen by the nurse who takes a full history, does also a physical examination, and then later on they come together with the doctor to make a treatment plan. So some of the assessments are also done by the doctor. The doctor will do like a quality of life assessment, the frailty assessment, then the hearing and cognition. So in order to make the history taking standardized, what we did was we embedded the questions into an electronic wizard, which the nurses administer. So we're sure that everybody is being asked the same questions. Next slide. So in addition to the history and the examination, we are also doing routine blood work. So we do check for how well controlled HIV is. We check for how well controlled the HIV is, and then we're also looking at other things like what is the renal function, random blood sugar, the lipid profile. And because we're also assessing nutrition, we look at vitamin B12, and we've been also looking at the full blood count. So after the full assessment, if there's a need for referral, we've been referring our clients. So some of them, if we've done the mental screen and we feel that they need extra support, we refer them to our mental and social health department, which is on site, where they can see the counselors, they can see a psychologist, or they can see a social worker. And then those ones who need to be seen by specialists who are in the tertiary hospitals are then referred to the central hospitals here in Harare. So I'm going to present the findings from the first 100 clients that we assessed between October 2022 and June of 2023. Next slide. Okay, so the median age for our clients was 69. And I would like to highlight that our clients were aged between 65 and our oldest is 92. 69% of our clients were female, and the median time since HIV diagnosis was 16 years. So our clients were quite treatment experienced, and the median time on antiretroviral therapy was 15 years. So I'd like to highlight that in terms of HIV control, most of them were all of them were well suppressed. 100% of them had viral loads less than 1,000. And if we then look specifically at 94% had viral loads less than 50. Next slide. So in terms of comorbidities, they had a median of 3 comorbidities each, and this is excluding HIV, and they were on median of 4 medications each. So if you look at the graph, it's showing the pre-existing diagnosis before they came for the clinic. So 80% of the attendees were hypertensive, 20% of them were living with diabetes, and 43% of the attendees were living with chronic kidney disease. So the most striking finding after the comprehensive geriatric assessment is that although these people had known pre-existing diagnosis, we still managed to 86% of the attendees received a new intervention as a result of a comprehensive geriatric assessment. Next slide. So here I'm going to more specifics about some of these interventions. So the interventions include a diagnosis or a referral. So in terms of the diagnosis, the most common diagnosis that we found was vitamin B12 deficiency at 55% of our attendees. And then in terms of frailty, where we're looking at lack of physiological reserve, 50% of our clients were pre-frail, and 43% of them had a high cardiovascular disease risk and they required statins. The other things that we found, which were also striking, 26% of our clients had either depression or anxiety, and we found that 21% had some degree of cognitive impairment. Then visual impairment, 19%, osteoporosis 18%, hearing impairment 12%, and then 9% of our clients were frail, and 3% of our clients were diagnosed of prostate cancer, and 1 was diagnosed of vaginal cancer as a result of the full comprehensive assessment. Next slide. Okay, so what lessons did we learn if we're trying to summarize the results? So integration of a comprehensive geriatric assessment in routine HIV care highlights that there is a high prevalence of multimorbidity and also complex needs of people who are living with HIV. There's a high prevalence of non-communicable diseases in a cohort of patients who have got well-controlled HIV. So there are a number of issues that we managed to pick up, which would not have been picked up on routine HIV care. So it means that we need to have targeted assessment of geriatric domains. Next slide. So one of the other lessons is that minimal training is required to teach nurses how to conduct a comprehensive geriatric assessment. What we did note is that there was a time factor. Of course, a comprehensive geriatric assessment is quite time consuming, but despite this fact, we still felt that it was quite necessary because we managed to pick up a lot of other conditions which would have been picked up if we hadn't done the comprehensive geriatric assessment. So the data that we picked up, it will really help to inform a lot of important clinical management issues. Next slide. So what are the next steps? So far we started with people who are above the age of 65. We're hoping to expand and start with people who are aged 50 and above so that we can pick up some problems at an earlier phase when we can still intervene. We also want to assess the effectiveness of the comprehensive geriatric assessment. And we also hope that our model is going to help to influence in the formation of a gold standard in the formation of a comprehensive package for older people who are living with HIV. Next slide. So as a closing remark, if you're still sort of on the fence about whether it's worth having a comprehensive geriatric assessment, I'll leave you with some of the comments that we received from our clients. So the first one, after the visit, one of our clients said, "Today, I have come to the hospital. When I've been coming for the other visits that I've been attending, I've just been coming to get medication." Another one felt that they were fully treated. They felt that nothing had been left out from their assessment. And the last one, they said that they had been coming to our clinic for years, but on that particular visit, they felt that they had never been evaluated as thoroughly as we had done. I'd like to acknowledge and thank our clients at Newlands Clinic and the Newlands Clinic staff, the Rudy Luthi Foundation, the members of the geriatric clinic team, as well as one of our mentors, Professor Celia Gregson. Thank you.
Thank you. My key takeaway from this excellent presentation, if you ever doubt the need to integrate treatment of non-communicable diseases with HIV, then she has provided the answer. 86% required intervention. All of them have their viral load suppressed, but they had up to about 40, 50, is it 80% had hypertension, 20% had diabetic. Sometimes, maybe when we go back to the crowd, to the listeners, we'll come back later to see. Probably, maybe even because of lack of intervention, those with diabetics will have developed complication and died along the road. We don't know, but excellent finding. Thank you. Let's open it up. We still have about maybe 7-8 minutes. So please, let's keep the answers very, very short. Yes, we start 1, 2, 3, 4, 5.
Thank you very much for the excellent presentations. Both of them are really good presentations. Thank you. Both of them were in HIV populations. And I know the chair is, or moderator is from CDC. What about those who are not HIV? Eh? We need to find, because these things are not only in HIV population, they are as well outside the HIV. We need also to do similar interventions in non-HIV. In my country, I come from Uganda, some people are now wishing they had HIV. Because that's when they get all these comprehensive interventions. I wanted to ask my sister, Charlotte, the 80% hypertension, the 20% diabetes, and the 43% chronic renal disease. Were these new diagnoses or these were already known diagnoses? And what proportion of those, if any, were new diagnoses? That means they would have gone without knowing these conditions and therefore untreated. I think those were my issues. Thank you very much.
Quickly, let's make it very quick so that we can go around and get as many as possible.
All right, thank you. He's asked one of my questions, what about those without HIV? And I just wanted from Dr. Mtengerere, who's doing his interventions in the community. How are you balancing provision of these services to the HIV positive patients and the HIV negative patients at the same facility? Thank you.
Thank you. I'll do justice to time. For Dr. Charlotte, can you maybe comment a bit on the retention in care? Because we see a good value separation. How's the retention? And in that model, there's any provision for doing home visit, because some of the the geriatric will not be able to come to the facility. So the data are so impressive: 80% of hypertension and 40 for, I think, 20 for diabetes. My question goes to the first presenter. Why did you start with diabetes? There's any particular reason? Because all of them are part of the major non-communicable disease, as you can see: diabetes, hypertension, part of cardiovascular disease, as well as the chronic kidney disease. Thank you.
Thank you very much for this opportunity. I'm Alice from Cameroon. I'm very happy to be in this one. This session, we really know that the challenges that we have is because, as he said at the end of his presentation, the HIV program is free. Meanwhile, the non-communicable disease is not free. So I think while waiting to mobilize more of funds, we'll even try to see how we can do the tests of diabetes and hypertension to those patients living with HIV. So my question is to know, we saw the result that were presented. I just want to know whether in those health facilities where the survey was done, I just want to know whether you offer services for non-communicable disease free, or what are the strategies that you put in place to come out with those results. Thank you.
We have a question online. Can we, the online person, please ask the question so that we balance it? Online? Okay, please read it out. Yeah.
So it's Oluwakime Sowale. He said, how do we address issues with access to medications for managing NCDs?
Okay.
Thank you. We will have to stop there because just that last one, and then we'll stop.
Thank you so much.
Yeah.
Thank you so much. My name is Dr. Ona from Tanzania. I wanted to know, how are we mitigating the costs of access to treatment? I think most of that question has been asked. Only that. Thank you.
Thank you. Thank you so much. I realized I didn't introduce myself at the beginning. Thank you for making me realize that. I'm Mohammed Abdulaziz. I head the Division of Disease Control and Prevention at the Africa CDC in Addis Ababa. So, excellent. You could see the kind of questions, interest your presentations have generated. So let's start with the lady. You answer maybe 1 minute because we have gone over time, and then we'll come to you. Thank you.
Okay, so there was a question on interventions in people who are not living with HIV. Unfortunately, our clinic only sees clients who are living with HIV. And then there was a question on the NCD diagnosis, the hypertension. So we offer a comprehensive package. So all our clients get blood pressures checked, we check the random blood sugar, we check HbA1c. So all these were known diagnoses before they came for the comprehensive geriatric assessment. Then there was a question on, so how do they get drugs? So as part of the comprehensive package, we are able to offer them NCD treatment as well. So it's a one-stop shop, even the ones that we mentioned that they were put on statins or the ones who had vitamin B12 deficiency, we are able to offer it at our facility. I think our clients are quite privileged in that aspect. Then there was a question on home visits. So far, the ones who were supposed to attend the clinic were able to come. Sometimes they have to be accompanied by caregivers, but in the event that we really do need to have a home visit, we've got our mental and social health department, where we've got someone who can go and do a home assessment. Then unfortunately, I don't really have an answer in terms of retention in care for this cohort. But a lot of our clients have been with us for quite some time. But unfortunately, I don't really have the actual figures. Thank you.
Thank you so much. We'll go to, please.
Okay. Okay, thank you so much. So there was a question also on balancing of those with HIV who are HIV positive or negative. So in our case, we've been privileged because our project started supporting the people who were HIV negative. So we're just supporting everyone in general, whether you're HIV positive or you're HIV negative, you will just receive NCD services at the facilities that we support. And then on why we chose DM screening and not the others. So initially we chose DM because DM was already our stronghold. We've been offering diabetes services since 2018 at these facilities. So for us, it was easy to start with DM and integrate the screening into people living with HIV. But we also noticed that there are also some services, say for example, for screening cervical cancer, which are already present at these facilities. And so, you know, when it comes to others like diabetes, they were not supported in cervical cancer screening. It's supported by other partners. So that was also the other reason why we chose to start with DM. But however, our aim is also to include the other NCDs. So for this one, we just wanted to get the experience and see how it is. And then using these lessons learned, we can then add some more NCDs among people living with HIV. And then in terms of the interventions, so our project it also gives a holistic, a full package for the NCD patients. So whether it's among people living with HIV or not, we just support the ministry with diagnostics and management, which will also include the medications. So it means that these people living with with these people with the NCDs, they also get access to medications. But however, there is still need for more or advocating for more funding towards availing these medicines, because even the support that we give as an organization is not enough. It can be enough maybe to cover maybe 2 months per quarter, because once you start offering medicines for the NCDs, you start to have an influx of patients even from the outside catchment areas of these facilities. So it means that those other facilities, we just need to advocate for the government and other bigger partners to chip in terms of NCD medicines. Thank you so much.
So colleagues, ladies and gentlemen, we're coming to the end of this event, but let me make some very high level things that has come out from these two excellent presentations. First is that there is comorbidity between HIV and NCDs, and the problems are much bigger than we thought. While we've been able to take care of the HIV component, the NCD component it remains a big challenge, and we'll have to work to see how we support this cohort, this population of people to reduce or eliminate non-communicable disease as a threat. And thank you, my brother. It's not just for people with HIV, but generally. Now, and this brings about the bigger question. Even for both presentation, you can see what are the implications for the health system that we are running today. What solutions can we bring